Welcome everyone to the Wealth of Health podcast. My name is Ahmed, and with me as always is Dr. Paul Jenkins, consultant physician and endocrinologist.
Welcome.
Today's topic is prostate cancer. Paul, what is this prostate gland that's causing all of this pain and agony for men? Can you tell me what it is, please, and where is it?
The prostate gland is it's a walnut-shaped gland, about the size of a walnut, situated at the base of the bladder. Yep. And through that, the tube which expels urine and semen passes. And the function of the gland is to produce nutrients and support for sperm.
Right. So it's I also heard it makes PSA. What is PSA?
Yeah, PSA stands for prostate-specific antigen, which is a substance that is made by prostate cells, but importantly, both by benign cells, but also cancer cells. But it's made more by cancer cells. So if you have prostate cancer, then the level of PSA in blood, it tends to increase.
Okay, and we'll come to that a bit later, actually. But we also know it's a gland. So what is the function of a gland?
A gland is any organ in the body that produces a substance. Classically, and I'm an endocrinologist, so endocrine glands are your thyroid glands, your testes, which make testosterone. So they make male hormone or make hormones, but other glands secrete other substances, and the prostate is one.
That helps in the function of the body. Okay, so what happens to that gland as we get older?
The prostate gland in men generally tends to increase in size. As we get older, it slightly enlarges.
Okay, do we know why?
It's just part of the
aging process.
Getting wiser.
So,
one of the downsides of getting
not
increased wisdom, you get the enlarged prostate, and that itself, though, can cause issues. And it's very common. And one of the issues is that those symptoms relating to benign enlargement of the prostate.
Right.
So in medicine, that's called BPH, benign prostate hyperplasia. They can often mimic the signs of prostate cancer because they're both caused to enlargement of the prostate.
So it's very important, I think, that people do not just get the sense of impending doom when they start getting symptoms. So let's talk about the symptoms a little bit, and then differentiate maybe between the severity of those symptoms if it's just part of the normal aging process, or if you are, potentially getting a prostate cancer.
Yes.
So what are those symptoms, generally speaking?
Okay. Well, if you think of the location of where the prostate gland is, yes, so it's at the base of the bladder, yes, and your urethra, which is basically the tube through which urine passes, goes through the middle of the prostate gland. Okay.
Right.
So if the prostate gland enlarges, it can constrict the urethra. So the tube, your hose pipe through which you're peeing, becomes tighter. Yeah. So your stream of urine becomes less powerful. So you can't pee up against the wall quite as hard as you used to. You get a little bit of, you call it hesitancy, a bit of stop-start of the flow.
Yes.
You get a little bit of dribbling, terminal dribbling. You don't empty your bladder completely.
Yeah.
Because it's at the base of your bladder, which is powerful sensation, which it tells you when you need to go to the toilet, because your bladder is distended. You can get slightly false signals saying, oh, I want to go past water, without it being full bladder. So you're going to the toilet more, wanting to go to the toilet more often. And especially at night, you tend to get up at night more commonly to try and pass water.
So that is one of the things, isn't it? The most common thing is that, people getting up at night frequently to go to the bathroom.
Yeah. And a more sort of, so all of those symptoms are the same with BPH, benign enlargement, and can be with prostate cancer. A more concerning one for prostate cancer would be if there was blood in your urine or semen, because that's more commonly comes from a prostate cancer than BPH.
Or semen in the urine?
No, it's blood in your semen.
Oh, wow. Okay. All right. So, but if you do have that, it's probably a bit more advanced.
Well, not necessarily, but
Okay.
yeah.
So it's important then to know that a lot of people will experience the majority of those symptoms, and it's still, it doesn't mean that they have prostate cancer.
Absolutely. Yeah.
Right.
Yeah. But you should be checked out for it and screened.
Okay. So what would be the most common risk factors?
Most common risk factors for prostate cancer probably is age. So the incidence dramatically increases after the age of 65. The second one is family history. So if your father had prostate cancer or your brother, then that's a significant risk. For reasons we don't understand, the incidence is much higher in black people. So they are particularly at risk. And then you have some more sort of generic risks. Obesity is associated with increased risk of prostate cancer. It is for many cancers, for reasons we could speculate. Lack of exercise, is it? And some people say diet. Yeah.
Right. And I will come back to the exercise part. Okay, so if someone is experiencing those symptoms, what should they do to get tested?
The first test, and probably the most widespread, and certainly from a public health perspective, is blood test for PSA. It's a simple blood test. It's it's a cheap test. Now, I know this is controversial, and there's been a lot of debate recently about it, whether the NHS should offer it to men, at what age. To my mind, all men should have a PSA test. Yes, nowadays over the age of 45. Yes. Against that, people say, well, the PSA isn't very accurate. There's a lot of false positives.
Right.
So, and that's the same, to be honest, with a lot of people against all forms of screening. It causes, false positives, false worry. Yes, I would much rather, in my mind, know if something is a potential issue than just ignoring it completely and not knowing what was going on.
So how can you overcome the potential false positives or false negatives that you can get from a PSA test?
Okay, well, false positives, it can be increased by exercise. So you should abstain from exercise for a couple of days before, especially cycling. We can come onto that
we'll
one.
come to that later.
Sex can increase your PSA. It's increased in any inflammation of the prostate gland, so something called prostatitis can markedly increase it. We've discussed the benign enlargement of it, so BPH will cause your PSA to be increased.
Okay.
Those are probably the main causes. I will counter that by saying, well, if you've abstained before your blood test, you've abstained from sex and exercise for 48 hours, yes, it could be prostatitis. That usually makes it significantly higher. Yeah, if your PSA is high, you would then have it repeated, say, after 4 to 6 weeks. Like all things with medicine, if you have a recurrent trend and it's consistently high, then okay, this needs further exploration. Yes, it could certainly be, in the majority are going to be BPH, but you don't want to miss is a significant prostate cancer. Yeah.
True.
So, and as always, if your PSA is slightly high, you keep an eye on it. Okay, you repeat it, say 2 months, 6 months, and if it's starting to increase, you need further intervention.
Okay. So let's say, I mean, you mentioned this is probably from a public health perspective, this is an ideal scenario. But what if I want to know for me as an individual perspective, and I want to know once and for all, and I don't want to go and repeat tests all the time that I know, are not 100% accurate. What should be done as a definitive tool to diagnose that disease?
Okay. Well, the studies come out in the last few years is a combination of a PSA blood test and a powerful MRI scan of your prostate. And that's using one of the more modern scanners, a so-called 3T, which is a powerful magnet of it, because that allows enhanced resolution of the prostate. So you can then image the prostate gland in great detail, and you can see any areas of basically any abnormal areas within it that could be suspicious. And an experienced radiologist now will then look at the scan and they can grade it, the various terms they use, Likard or PI-RADS, from 1 to 5. 1 being on appearance only, 1 is completely benign,
Okay.
2 looks pretty good, 3 borderline, 4 suspicious, and Likard 5 is this looks nasty. Yep. And so if you combine that with the PSA, that is currently the most accurate gold standard on an individual basis. Now, the public health, the NHS, does not have sufficient 3T MRI scanners to do every man.
Right.
But even starting with just a PSA test for everybody would be
a good starting point.
Now, I will now counter all of this by saying that around 15% of prostate cancers don't make PSA. So they're PSA negative. So your PSA can be normal in your blood test, but you've still got a prostate cancer.
Wow. Okay. So in that case, the MRI would be the only way then.
Yeah. Yes.
That's very interesting.
And prostate cancer, sadly, is the most common cancer affecting men. 1 in 8 of us are going to get prostate cancer.
Okay.
That is clinically important, yes. And around in the UK, 500,000 men, 500,000 men are living with or subsequent to the treatment for prostate cancer. So
it's quite a large number.
That is a big number. Then to further add fuel to the whole mix, if we look at men, elderly men, 80 plus, 80% of them will have foci of prostate cancer if you look carefully within the prostate gland.
Okay.
So you can get small cells of prostate cancer, but they're not doing much.
Right.
So this is where the whole issue comes in, and those people who don't want to screen for it say, well, it's not causing any issue. Yes. But as always, with all diseases and many cancers, you want to know those that are relatively indolent to separate those that are more aggressive, and you want to treat. Because what you don't want with any cancer is to miss aggressive ones which are spreading, and then by the time they're diagnosed, it makes 100%. Treatment much harder.
And it feels a bit strange to me, like I've always had a thing with the fact that it's been decided for me that this test is not conclusive and not necessarily, you shouldn't worry about it. I feel like I should give me all the information and let me decide for myself.
I completely agree with that. It's up to me to decide what is important and to make those decisions for me, because we're all different. And everybody has, in my practice...
True, some people don't want to know.
Exactly. Well, everybody has different... So it's for us to make informed decisions of the pros and cons of the test, the limitations of it, the false positives, the false negatives, the sensitivities, and then to decide.
Okay, so someone had prostate cancer, or someone has tested positive for prostate cancer. Are all prostate cancers terrible or terminal or that severe, or are there different types of prostate cancer?
As I was saying, there is a difference in the aggressiveness of it.
Okay.
And it's the same with many cancers, same with analogy with breast cancer. So some prostate cancers don't do very much, and the treatment options for them is very often watch and see, the so-called in medicine a conservative approach. Just not to ignore it, but just to, it doesn't need aggressive treatment. Keep an eye on it and see, and if it changes, then you can act on it. But other cancers start, for reasons not always be apparent, genetic variations in it, start more aggressive
from the
beginning.
Yeah.
So those are it's a mixture, and you don't want to miss the aggressive ones. And first of all, I always say, I want to know myself, get all the information, and then decide and make an informed decision.
Right. You said almost 15% of cancers do not produce PSA, but almost all prostate cancers will produce the symptoms we spoke about?
No, not at all. No.
Really? So someone
if you have a walnut-shaped gland and they're located in the periphery of the gland,
yes,
away from the base of the bladder, away from the tube, your urethra, then it can grow quite happily without causing symptoms.
Okay. So that's a very interesting point then. Yeah. So is it a matter of, if you're 45 plus, just go and get tested?
I would. Yeah. Yes. Now, I mean, again, straying slightly into public health policy, and there's a difference between, you know, what might be available on the NHS and what is appropriate for you as an individual. I'm coming much more from what's appropriate for you as an individual.
Yes.
But, you know, this is a whole issue about screening, isn't it? On an individual basis or on a government NHS public health basis. Yes. I believe, you know, once you get 45 plus, we are, I know there's a slightly cynical term amongst medics, going into Sniper's Valley. You know, we are at risk, highest risk of all sorts of disease.
More vulnerable.
More vulnerable. It's just statistics, that's when disease is most likely to hit. So if you want to reduce your risk of getting those diseases, prolong your so-called health span, which is the decades, hopefully, when you are still active and disease-free and can carry on doing the things you enjoy the most, then there is the option now, and medical technology is there to screen for many, many diseases and detect them at an early stage.
Right.
And amongst men, prostate cancer is one of the most important and common cancers.
Yes, and you know, public health can do whatever is in their interest. I would like to do what's in my interest as an individual.
And of course, public health has, you know, there's a limited budget, so I completely understand that it can't do everything.
Of course,
that is optimum, but I think people can make their own choice and decision. And a PSA test is not expensive. No.
Right. Okay. So how can, I know it's not always possible with cancers, but can men actually protect their prostate a little bit more? I mean, is there any lifestyle changes that can help reduce that risk?
Well, you can't change the biggest factor. You can't change your age.
Yes, of course.
You can't, well, only it's going one way, and it's not a good way.
Yeah.
You can't change your family history, your genetic predisposition. You can't change your racial origin. So those are the three big ones. You can change some of the softer risk factors. So do exercise, lifestyle, lose weight, have a healthier diet. And those are applicable for many diseases. So yes, you can do that.
Okay, so we said we're going to come back to sports, and I want to talk a little bit about this because a lot of men, for some reason, in the recent years, have taken up cycling as a sport. It's too much lycra for my liking, so but it is what it is. There's been a little bit of a conversation of, you know, sitting on those thin, you know, hard seats and cycling for extended periods of time. Does that have any negative impact on the prostate or on the whole neighborhood down there?
You're right. It is topical. It's been precipitated by this, you know, very sad case of Sir Chris Hoy, you know, almost decorated Olympiad cycling with his advanced prostate cancer. There have been some studies a few years ago showing an association between a lot of cycling, you know, more than, I think it was 8-9 hours a week, and an increased risk of prostate cancer. Now, I won't say how, I'm not certain myself of the robustness of it, just to say it has been raised and there is an association. I think that's what probably the best you can say at the moment. Okay. I certainly have had patients, when you say about down there, I've had patients with significant erectile dysfunction who are keen cyclists, you know, with no other risk factors for it. So
other than cycling?
Yeah, all of their hormones are normal, yes, all of their blood flow is normal, they have no risk factors, they're not diabetic, which is another risk factor for this. We're slightly digressing, but the only thing I could tease out was they were very keen cyclists. And there is a suggestion that if your seat isn't a professional one where
it's not optimized,
or not optimized, and so you're putting pressure on the nerves around there, the perineal nerve and the prostate, does that have adverse effects? I can certainly see correlations there. Or I can make a case why there could be an association between the two.
You said 7 to 8 hours a week.
Yeah, well, that's what the study said. I mean, I think all I would say is there's a putative and circumstantial link between them. But I wouldn't say it's definitely if you do more than 8 hours, you're increasing your risk or lessen it. Just there is a link between them.
Okay. And does it make a difference if it's, an hour on Monday, an hour on Tuesday versus, 5 hours on a Saturday? Because I think that tends to happen.
Yeah.
This is much longer, but for one period of time.
I'm not aware of that.
Okay.
So I wouldn't, in the famous words,
Remains-
no comment. I
remains to be
can't comment. I don't know
No,
the
fair
data.
enough. Fair enough.
enough
We'll
on that.
watch the space.
Yeah.
Okay. And what would be some of the treatment options of prostate cancer? I know we have Professor Hashim Ahmed with us today, and we're very proud to have him because he is the leading voice on prostate cancer treatment. But what are the stage 1 prostate cancer treatments that are available out there?
Well, I think that depends. First of all, you have to determine the stage of the prostate cancer.
Okay.
So you've had your screening, your PSA is raised, maybe your MRI is suspicious. Yes, you then need to have it confirmed, and so you'd have a prostate biopsy. Yeah, so like all cancers, you suspect cancers, you need to get a bit of tissue. Yeah. Now, prostate biopsy is not a straightforward procedure, nor is it a very pleasant one, just of the location where the prostate is. So you either go through the rectum, so an ultrasound scan, and then pierce a needle through the wall of the rectum into the prostate cancer, which is right next to it, or you go straight through the skin in. The rectal one, you can imagine, there's a lot of, it's not a clean area, so there's a big risk of contamination and indeed septicemia. You get infection as a risk of the biopsy.
I've been hearing a number of stories where people went for the biopsy and they ended up spending days in the hospital because they got it. They had an infection and they need to be on a very strong course of antibiotics.
Exactly. They try and cover it nowadays with prophylactic antibiotics, but even so with those, it is a very real risk. So that's why you don't want it unless you're, as with any test, the potential benefits outweigh the downside. Right. But it is sadly the only way of knowing it. And then once you have a prostate biopsy, they stage it, something called the Gleason score. So they look at the aggressiveness of in a biopsy. They take multiple samples around the prostate and the suspicious area. So you'll have a number of samples of prostate tissue, which are then sent to the laboratory. Right. The lab will analyze each of them for the degree of aggressiveness of any cancer. And then the Gleason scores, they look at the lowest score, the highest score, and put them together. And a score nowadays, it's generally, score, and each one is staged 1 to 5, scored 1 to 5. Most of them are from 3 to 5. So an aggressive cancer is sort of a Gleason score of 8 to 10.
Now, this is different than what the score that the radiologist gives when they MRI the prostate. Yeah. So it's very important to differentiate that so that people, do not get a report and freak out after they have an MRI of the prostate. This is a different staging or scoring method.
Correct. Okay. So this MRI scan has shown the likelihood of it might be a prostate cancer based on the appearance of the gland. The biopsy is a definitive yes or no, you've got cancer. And then if it is cancer, this is the aggressiveness of it. So that is needed first to determine the optimum treatment.
Right.
But you would also, if you did have proven to have a cancer, then have further tests to determine if the cancer was confined to within the prostate gland or had spread beyond the gland to the local lymph nodes and or beyond to bones. So as it was sadly with Sir Chris Hoy, it has already spread to the bones. So that involves an MRI scan, if you haven't already had one, of your prostate and the surrounding pelvis, and then often a bone scan, which will determine if there's spread to bones, the skeleton.
Right.
And once you've got all of that information, then you can discuss with your urologist what is the optimum treatment for me.
Right. And what are some of those treatments?
Well, we're going to discuss. We've got the expert coming in, but it can be, as I said, watch and see.
Right.
It can be just hormonal treatment. Okay. So testosterone does not cause prostate cancer, but if you have a prostate cancer, high testosterone can cause it to spread more easily. Prostate cancer cells have androgen receptors, so testosterone receptors on them, analogous to estrogen and breast cancer.
Okay.
So
That might be, I might deviate a little bit because testosterone replacement therapy is now a very, very topical issue. And people are singing the praises of being on testosterone. If you're on YouTube, there's literally about 1,000 video a day of an older guy who's saying, "Since I've been on testosterone, life has been unbelievable." So that's something that some people need to watch out or be wary of. So having high testosterone levels can increase the potential of the prostate cancer to spread.
correct. Important differentiator. And look, I prescribe a lot of so-called TRT,
Yes.
testosterone replacement therapies, as
Yeah.
an endocrinologist, and I'm a great fan that in some patients, it can be, some men, can be really transformative. And maybe we'll have another podcast specifically on TRT. Because
Yes.
it is such the pros and cons of it, because, yeah, we can discuss there are a lot of myths and pseudo stories around it. But you're right that if you're on testosterone replacement, you need to keep an eye on the PSA. Because testosterone replacement can cause the prostate to grow. So you have the benign enlargement of it. But if you are unfortunate enough to develop prostate cancer, it can make that grow more aggressively. So if you have proven prostate cancer, one very common treatment to start with is to switch off the body's testosterone production. Right. So the injections, you can have so-called gonadotrophin releasing hormone analogues, which switch off the signals from the pituitary gland to the testes to make testosterone.
Okay.
So, and then you get into the various interventional treatments of it and varying degrees of surgery. And this has shifted massively in the last 10, 15 years. We've got all sorts of new developments in it, because we need to be wary. And I think you alluded to early on, just the location of the prostate,
Yes.
where it is, and the fact that the nerves around it and the blood supply around it also supply the penis. So any intervention on the prostate has quite a high risk of damaging those nerves and arteries, and so you get erectile dysfunction, impotence, afterwards incontinence. So those are all very significant factors to take into account when you and your surgeon are deciding on the appropriate treatment for you.
Right. I think this is then the perfect segue so that we have a look at the conversation we had with Dr. Hashim Ahmed, Professor Hashim Ahmed, sorry, and then we will come back and discuss it. Professor Ahmed, it is a pleasure to have you with us. You are one of the world's leading urological surgeons, and you are known for pioneering groundbreaking changes on how men are diagnosed and treated with prostate cancer. You also won several prestigious awards for your research, and you are an expert in many surgeries like HIFU and cryosurgery. And you are the voice of authority on MRI and minimally invasive diagnosis methods and treatment of prostate cancer. It is a pleasure to have you on the Wealth of Health podcast.
Many thanks, and I'm delighted to be here, and thank you for the kind invitation.
Thank you very much. From your experience, are there any lifestyle changes that impact the possibility of developing prostate cancer?
Yeah, it's a really good question, and I know a lot of my colleagues can sometimes be skeptical about lifestyle changes when they're dealing with cancer. But if you don't have a genetic risk from your family, then what is causing the cancer? It's got to be something to do with the environment and extraneous factors. So living a good lifestyle, having a good diet is really important. So what specifically can you do with respect to prostate cancer? There's really good evidence that aerobic exercise, swimming, jogging, cycling, brisk walking 3 or 4 times a week for 20, 30 minutes where you get a little bit breathless, that aerobic exercise is protective. And not only will it do you good from a prostate perspective, it will do you good from other aspects as well. And then there are some foods which, if you can increase the intake of, you don't need to go absolutely bananas with it, but if you can increase the intake of cooked tomatoes, the cooking releases a chemical called lycopene, and that has a direct protective effect on the prostate. Mixed nuts, but don't have it with salt because that will increase your heart disease risk. The brassica vegetables, so things like cauliflower, broccoli, kale, Brussels sprouts, are all really good for you. pomegranate. You can buy juice and the fruit itself from most supermarkets now. And then lastly, green tea. So if you can drink 1 cup of green tea a day or as much as you can in a week, that would be great. If you don't like the bitter taste, there are flavored ones now, and you can always add a little bit of honey or sweetener or whatever you, just to make it a bit more palatable. So all of those things are important. And even if you don't have a diagnosis of cancer, and then if you do get diagnosed with cancer, there's reasonable evidence, not great evidence, but reasonable evidence that I advise my patients to do this, to change your lifestyle and your diet in that way, that it reduces the risk of recurrence of cancer after treatment. And also, if you're on monitoring for a low risk cancer, it reduces the risk of that cancer getting worse. So it's all good, and it will obviously make you feel better and help with other disease preventions as well.
Can I just, Hashim, just come in on that point? Just one thing. Firstly, everything seems to come back to broccoli, but
Yeah,
yes, we
yeah.
need to keep eating that. But on a second point, which you mentioned about absolutely, cardiovascular exercise, but it's the issue of cycling. What is there an increased risk? And clearly, Sir Chris Hoy, the tragic case of Sir Chris Hoy recently, has raised some maybe further awareness of that. But even before then, there was a suggestion. Does cycling, is that a risk factor or not, in your opinion?
No, I don't think the evidence shows that it's a risk factor, and certainly it's a protective. What cycling does do, though, if you have a PSA blood test, and we'll probably speak about this a bit later, you mustn't do any strenuous activity, particularly cycling, but any kind of strenuous activity or sexual activity, I say in the 48 hours before the PSA test. And I've seen PSA tests done after that high. We repeat it with a calm 2 days, and they go back into the normal range. So that is definitely an issue. So Chris Hoy's case is really sad. He had a very strong family history, and so there's a real debate about how do we handle those men, how do we raise awareness so that they start testing their PSA at an earlier age, maybe at the age of 40 or 45. And I think by his own admission, he hadn't been testing his PSA until he had symptoms.
And another question is an enlarged prostate, because it's something that a lot of men over the age of 40 and even evidently now even younger than that, is an enlarged prostate a definite precursor to prostate cancer?
No, and it actually causes a huge amount of confusion because the vast majority of prostate cancers are small. They occur on the periphery of the prostate because the prostate has two zones, and it's the peripheral zone that develops most prostate cancers, and it doesn't cause any symptoms. So for the last 2 decades, of charities and stakeholders have been encouraging men with symptoms to get a PSA test. But actually, if you want to catch it early, the only way is to ask for a PSA test if you are asymptomatic, but to have a discussion with your GP to read around the pros and cons of doing a PSA test, because we'll probably come on to this. There's considerable controversy around whether we should be routinely testing for PSA. So an enlarged prostate, there's no correlation with prostate cancer unless that prostate cancer is very, very advanced and big enough to start to cause a compression on the urethra.
So within the majority of cases, if someone has an enlarged prostate, they should not need to be highly concerned, basically.
Correct.
Okay. And the third question for me, which I guess will lead on to a more technical side, I think the biggest fear with men is when they get their prostate treated, is erectile dysfunction an inevitable side effect of prostate cancer treatment?
Yeah. So, again, we've been remiss in the urological and oncological community about that particular side effect, we sort of almost dismiss it as not relevant. We're saving your life, so you should just be grateful. And sexual health, is one of those things that you just have to sacrifice. And it's a very, very important aspect of a man's quality of life, and their partner, and a great element of good psychological health and mental well-being as well. So I think it's a really important aspect of overall health and quality of life. So if you have prostate cancer, first of all, we have to look at what the risk of the prostate cancer is. If it's contained in the prostate, it can be low risk, medium risk, and high risk. If you have high risk disease, what that means is if we don't treat it aggressively, there's a good chance it will progress, spread, and reduce your life expectancy. There's also a good chance, even after treatment, that it might recur. So there's a much higher chance. So high risk disease, the equation, the pros and cons mean that we have to treat aggressively. And it's up to the man who's going through it to decide whether he wants that aggressive treatment. But if it usually involves surgery plus radiotherapy or hormones plus radiotherapy. So you're almost, I don't like the term, but it's sort of, from a lay perspective, you're throwing the kitchen sink at it, everything in the kitchen sink at it, in order to help with survival. And in that group of men, you will have a major impact on your sexual health and urinary symptoms as well. So things like leakage or getting up at night, going lots of times during the day, maybe even some back passage problems. And you have to decide if that improvement in life expectancy that treatment will give you is worth such a detriment to your quality of life. And that's an individual decision. Most men accept those side effects. If you have low-risk disease, the vast majority, 90 to 95% of men with low-risk disease, shouldn't have any treatment at all and should be on active surveillance. They should look at their diet, their lifestyle, and the vast majority will survive 10 to 15 years without the cancer affecting them in any way. And if the cancer does change, you treat it at that point without losing the window of curability. So you avoid the side effects of treatment. That middle group, the medium risk group, they have a choice, and you can go for surgery to remove the prostate or radiotherapy to irradiate the whole prostate, but that will give you a 30 to 80% chance of erection problems and anywhere between a 5 and 40% chance of urine leakage with surgery or radiotherapy. Really high percentages. For a group of men, that could also delay their treatment without any detriment to their life expectancy. So the improvement in life expectancy from treating medium risk disease is there, but it's a very small improvement over doing nothing. And so we've developed a minimally invasive approach in the UK. We've been leading this for the last 2 decades, something called focal therapy, where in eligible men, and we think about 50% of medium risk men are suitable for this. So 10,000 men every year in the UK are suitable, but don't even know about this. Something called focal therapy, where you target 1 or 2 areas of cancer in the prostate and don't treat the whole prostate. And that leads to a 5 to 10-fold decrease, 5 to 10-fold decrease in side effects. So virtually no incontinence and about 5 to 10% erection problems, night and day. And you don't compromise your life expectancy over 10 years. And the recurrence risks look to be very, very similar to surgery and radiotherapy. So that's a real revolution, but that's come from the fact that we are able to pinpoint, diagnose individual areas of cancer in the prostate.
And so, what can I ask? What are? I mean, this sounds like a phenomenal advance And as always, very elegant, trying to target the tumor itself without any of the sort of the collateral damage around it. And those techniques are what? One is the high intensity ultrasound, focused ultrasound, HIFU.
Correct. Yeah. So the most important thing is to localize, so MRI and biopsies. And then we can treat without making any cuts, without major surgery. So high intensity focused ultrasound, HIFU, involves a probe in the back passage, and we fire sound wave pulses that heat up the prostate to millimeter accuracy and effectively boil the tissue, but doesn't damage the surrounding tissue that we don't want to treat. The other modality that we use in the UK is cryotherapy. So we can insert needles into the tumor and freeze it down to -40, -50 degrees centigrade. And nothing survives that if you can accurately hit it. And then the third modality that we use is something called irreversible electroporation. And again, that's inserting needles into the cancer and you're electrocuting it, and that causes the cells of the cancer to effectively lyse. So what that means is the electrical current causes holes in the membrane of the cells, and they burst. So we are using those three modalities in a very complementary way. So not all tumors are suitable for HIFU, not all tumors are suitable for cryo or nanoknife, and we use the three depending on individual characteristics of patients and the cancer inside their prostate.
So we used to use or started to use some similar of HIFU for thyroid nodules in treatment of them. So but I found with that our patients found it very, very painful. Is it painful for the prostate?
Interestingly not. So paracetamol, ibuprofen is usually what they need. It is uncomfortable. I always say to men, we're destroying a part of your body, and your body needs time to heal. So give yourself a good 2 or 3 weeks to not do any work and relax. No physical activity for the first month. So it's a bit like if you have a burn on your skin. It initially swells up, it welts up. It takes a couple of weeks for that to settle down, and that's happening internally around your water passage. So very few need to use codeine for pain.
Okay.
It's uncomfortable, and that first week you do need to have a catheter because otherwise you wouldn't be able to pass urine because of the swelling. But it settles out. Every week gets better. Most men get back to normal activities after 3 or 4 weeks. But the recovery is much quicker than prostatectomy, where you remove the entire prostate, and that can take 6 to 8 weeks before you get back to normal activities.
Yeah, and all the hassles of a major surgery, and let alone the collateral damage on the nerves and the blood vessels. Yeah. So, but I mean, this sounds such a dramatic advance. But what is the availability of it within the UK and the NHS? Is it just a couple of few tertiary referral specialist centres of excellence such as yours?
Yeah, so that's a really good question. So it's been a long journey, and if you know about the innovation towards lumpectomy for breast cancer, hemothyroidectomy probably went through the same thing. All cancers have tried to treat just the tumor with a margin of normal tissue, and in prostate cancer, it's been just as fraught and just as controversial. People just can't get their heads around it. But the data now is really good, and that's leading to an increasing number of centres offering it. And one of my roles in the UK and internationally has been really about dissemination. I don't want men to travel hundreds of miles, to come to London, when they should really be having it locally. So at the moment, we have 5 or 6 NHS centres which offer it routinely outside of research, outside of trials, as part of the armamentarium of treatment options that they have. Obviously, it is also offered privately in a number of centres as well, but it is increasingly offered in the NHS. And over the next year to 2 years, we have another 10 centres who have looked at the data, have been reassured by the cancer control, the survival rates, and the side effect profile, and they're all actively looking to start a program in the next year. And we're really keen to support as many urologists to start this so that men in their locality can have it readily available. Ultimately, it's up to the man to decide between the pros and cons of each.
Yeah, no. And who does it? Does it require a lot of training? And is it more surgeons who learn the technique, or is it the radiologists with their skill in ultrasound probes, or combination?
Yeah, so I think predominantly it's urology based, mainly because unlike other organs, there's a very critical structure that runs through the middle, the urethra, which we have most experience with, and you can get the odd case where you do need to deal with a urethral issue, such as scar tissue or whatever. So it's in the UK, it's urologically led. There are some cases where we need our colleagues in radiology to come and help us, and we do joint cases. But and the skills are interchangeable. So in the future, we might end up having a specialty which is, interventional oncology, a bit like head and neck cancers, where you can have plastic surgeons and maxillofacial surgeons and ENT surgeons doing approaching the tumor in the head and neck in a different way. But so we might end up being in that approach in the future.
Okay.
So one last thing I want to ask, just because I know, again, here in the UK, this might be on a lot of people's minds, but there's a certain taboo of talking openly about it. So if a man is concerned about their prostate, whether because they have symptoms, mild symptoms, or they have a family history, what are the questions that they should be asking?
Yeah, so the first thing they should do, and it's difficult because, finding out where that information is sometimes difficult, but the NHS website is pretty good now and has some very neutral information, and the first question they need to ask themselves is, should I get a PSA test? Because once you get a PSA test and it's elevated, whatever elevated means, you do start down a pathway. And that pathway often means more tests. It might end up meaning unnecessary tests in some men, and they need to understand that and the pros and cons of that test, which sometimes can be invasive. But in the UK, if you have an elevated PSA, you normally have an MRI scan first. And that's non-invasive. It's very easy to have, unless you're claustrophobic. And that gives us a huge amount of information. And if it shows something suspicious, then we can see where it is, and we're much better at targeting that area and doing a biopsy, taking samples of tissue in a much safer fashion. So the diagnostic process is safer, but it isn't without its risks. And that's the first thing to understand. And then second thing is, if you do go down that route and you're eventually diagnosed, you might have a treatment that significantly impacts on your quality of life. And the reason why screening is controversial, why we don't send out a letter to every 50-year-old plus man and say, dear Mr. X, please have a PSA test with your GP. We want to check for cancer, is because at the moment, the epidemiologists, the statisticians, those who sit on the National Screening Committee look at the data, and the harms at the moment seem to outweigh the benefits. And one of my jobs is to try and bring those harms down so that they no longer become a factor. And that's through MRI, targeted biopsies, targeted treatment, no treatment if the cancer is low risk. There's a lot of factors going on, and it requires a bit of an effort from a man to look into that. And that's sometimes unfair. Not everybody can understand all of those nuances. But do as much reading as you can, look at as many neutral videos and information sources as you can. And then GPs are busy, but they are willing to have that discussion with you. And they are, what I would say, your advocates. They don't have, I'm biased, I'm a urologist, I make my career out of this. And so that in itself is a big bias. but GPs don't have skin in the game, so they can advise you. And ultimately, if you want to have a PSA test, the vast majority of GPs will agree to do it. There are some GPs who refuse. They shouldn't really, but they can refuse. In that case, you might want to speak to a charity that does a PSA test if you still want to get the PSA test, or speak to another GP in the same practice and see if they will agree to do it. But yeah, just try and learn as much as you can before you embark on the journey.
I mean, I understand some of the controversies about the PSA on a epidemiological and an NHS-funded model, but by not having one, you do run the risk that you will miss your prostate cancers.
And
I
that's
fully accept the path of maybe not all cancers, and we all know not all cancers need treatment, and the active surveillance for them is a wonderful model. But you want to be in, to my position, I would want to be able to make that decision myself and not miss a prostate cancer, which might impact on my lifespan.
exactly, and that's the key, isn't it? Because we still have thousands of men who die every year from prostate cancer. And how do we square the argument of harms of overdiagnosis and overtreatment versus the harms of underdiagnosis and men losing their lives to the disease and the horrible impact that has on them and their families and society? We're losing, valuable members of our society. So it's difficult to square, and it's difficult when you have a screening debate, because screening is about systematically approaching everybody who should have a PSA test versus that individual decision making. And I think it's very important to raise awareness, because we don't have screening at the moment, and let's just keep that out of the argument. But if you are an individual man, yes, strongly consider the pros and cons, strongly think about the fact that we've done a huge amount to reduce the harms, and there may be a chance that we find disease in your case that could shorten your life, and finding it earlier is going to be better than finding it later.
Yeah. Okay, fascinating. And well, I think we could continue talking on this topic for an awful long time. There's a vast amount of really interesting developments, and congratulations on all that you've led, because the HIFU and the focal therapy, to my mind, seems like the most elegant and obvious way to progress, if you can, without reducing all of the collateral damage.
Yeah, absolutely. Absolutely.
Yeah.
Thank you.
Professor Ahmed, it's been an absolute pleasure having you with us. I'm pretty sure we might call on you again. And
I'd be delighted. And
thank you so
very
much.
kind
And
if you do.
if people need more information about the work you do, we are going to put a link to your website in our description.
That's great. Thank you very much. It's very kind.
Thank you so much for joining us today.
Nice to be here. Take care.
Well, that was a fascinating talk and summary of the options, the treatment options of for prostate cancer, which is clear they're changing in the last few years, and it's associated with much less side effects than they were before. But I think that's really all we have time for today. I think the take-home message is go and get your PSA tested for all men over 45. So
Definitely.
On that note, it's goodbye from me.
And it's goodbye from me. Please, if you like the episode, do not forget to like, subscribe, and ring the ding dong. Thank you very much.
Thank you.